Let's start upstairs today. You'll start on the 10th floor. So I can make sure that you can we just try, if you can just do just the first line for me, I just want to hear it from my side.
Sure. Hi, doctors. I'm Michael John Dement and very pleased to welcome you to the latest Genoa Underwriting Managers CPD event on telehealth and the transformation of medicine. Can you hear me? Cool.
Okay.
Brad, you good if I start?
Please do.
All righty.
Thank you. That's a bit dry. Yeah, thank you. Yep. I thought it was looking good. A bit much. Yeah, a little bit too much of everything.
Yeah, I think, sorry, I wore the wrong shirt. I'm sort of disappearing into the background a bit. Okay.
Okay, happiness. Okay, stand by, guys. Brad, are you ready?
I'm ready when you guys are.
Okay, stand by.
Hi, doctors. I'm Michael John Dement, and I'm very pleased to welcome you to the latest Genoa Underwriting Managers CPD event on telehealth and the transformation of medicine. As our practitioner pool can attest to, Genoa is passionate about offering its practitioners access to true value. We give our insureds access to choice, where your policy can be customized to suit your pocket. This is done by offering varying limits of indemnity and excesses, which also include the option of a zero excess. I'm joined by Dr. Brad FHIR, who will be delivering his talk on telehealth and the transformation of medicine. Dr. FHIR is an engaging speaker who has spoken all around the world on medico-legal matters. Please enjoy the presentation.
Very cool. Can we do one more just for safety, please?
Sure. Hi, doctors. I'm Michael John Dement, and I'm very pleased to welcome you to the latest Genoa Underwriting Managers CPD event on telehealth and transformation of medicine. As our practitioner pool can attest to, Genoa is passionate about offering its practitioners access to true value. We give our insureds access to choice, where your policy can be customized to suit your pocket. This is done by offering varying limits of indemnity and excesses, which also include the option of a zero excess. I'm joined by Dr. Brad FHIR, who will be delivering his talk on telehealth and the transformation of medicine. Dr. FHIR is an engaging speaker who has spoken all around the world on medico-legal matters. Please enjoy the presentation.
Hello, everyone, and welcome to today's presentation sponsored by Genoa, where we're talking about telehealth and the transformation of the practice of medicine. This is a big topic, and it's something that, whilst feels new to us, has been ongoing since around the 1700s. And I say around the 1700s because every time there's a new innovation in medicine, it transforms the way we practice. Telehealth in its own right has been evolving since the early 1980s. And so as we go through this presentation, we're going to talk about medicine versus health. We're going to talk about how we define a consultation. We're going to look at the Health Professions Council ethical guidelines and what we should or shouldn't be doing as it relates to how we practice telemedicine and telehealth. And then we're going to look at some global trends on how the digital world is affecting and transforming our practices on a daily basis. So the Alma Ata Declaration from the World Health Organization is that health is a state of complete physical, mental, and social well-being. And it's not merely the absence of disease and infirmity. So you will see on the right-hand side, I've put a a slide there and a graphic that's called transformative technology. One of the great privileges I've had was to work with a non-profit organization called Mudiro. Mudiro provides access to high quality local and telehealth solutions in northern Namibia to the residents of that area, up from Andara and across into the Caprivi space. Now, you'll appreciate in that area, there is not a significant amount of technology. There are hospitals, they are resourced as best they can be. And here, this image is an individual using their smartphone with a dongle doing ultrasound, where that image can then be beamed across to a third person to give a diagnostic opinion that supports or teaches or expands on the access to care that's given on a local basis. So it brings us to the question now, how do we define a consultation? And my question that I'm asking you is now, how do you define a consultation in the context of using digital technologies? The second question that I'd like you to think about is, can a virtual consultation be part of value-based care? Are you able to remotely fully understand and appreciate the patient's condition? Are you able to assess their malaise or the turgidity of their skin or their temperature or their general health status without being able to touch, see, and feel them? And touch in this case is slightly different from the challenges we're having in terms of our COVID challenges, where we have to wear PPE. Because even though we've got PPE on and we're wearing gloves, we're still physically able to be in close proximity to the patient. And that brings me to the next question of the three as we kick off. Is telehealth person-centric, and is it interoperable care? Can we use it in a manner where we can provide the best care using the most available resources for us? And I don't know if we know the answers to any of these, but each of these will be individual and specific to yourself. So we're going to go through this. I'm going to share some examples with you, and we're going to start with some background on where we are. So one might appreciate that we're in changing and challenging times. There's been a significant change in the use of artificial intelligence, machine learning, and the way that we apply that into our digital health world. And on this slide, I'm sharing with you a range of maybe just a very, very thin slice of the different organizations, companies, and solutions that are available. So you can see that Google, IBM, as two examples, Amazon as a third, now apply cognitive technology to big data to help us reach diagnoses on a more rapid and a more robust way. Babylon Health, also Your MD, is an artificial intelligence-based healthcare assistant. And there's chatbots that help us not only with diagnosis of the most common presenting symptoms in triage, but also to provide medication reminders, do appointment scheduling. And this has been rolled out in the NHS in the UK as part of their emergency room project. SimSensei is a therapy automation platform, and there it uses voice and face recognition to assist with diagnosis. And I'm not going to go through all of these, but you can see there with Helix, it's machine learning to allow responses to verbal questions, which is making the chatbots quicker. Then there are diagnostic tools allowing us to look at cardiac arrhythmias and heart problems. There's surgical robotic enhancements. And then we've got all of the pharmacogenomic based therapies, those, for example, based and used by Tempest. So I want to pause on this one for a moment, because what was interesting is in the Netherlands, they use a pharmacogenomic platform to determine the dosage of a medicine that's needed to get the right therapeutic effect. And they then place that onto a smart card with the patient's biometric and related data on. So when the patient goes to the pharmacist to fill their script, the pharmacist knows off the smart card how to adjust the dosage up or down based on the pharmacogenomic profile of that individual. So significantly, our world is changing. And often when I use the slide, I have a picture of the stethoscope on the slide from working with a neurosurgeon in Cape Town at one stage, having a conversation. And he said, why do we still use a stethoscope that's got a diaphragm and air conduction in order for us to assess or listen for murmurs and rails and other cardiac and physiological signs. If we're using a smart device to auscultate, and we're using smart devices to give us our blood pressure and our pulse oximetry, surely we should be moving to smart devices for other tools. And I remember very clearly, the first time I started in my practice, I had a mercury sphygmomanometer, and you would wrap it around the patient's arm, then you would put your stethoscope and you would take the blood pressure. I'm sure that there's many of you who can remember that. The other day, I had somebody come and they showed me that they'd bought a pulse oximeter, and you put it onto the finger and it gives the pulse and it gives the blood pressure and it gives your SpO2, and it's about the same size as a person's thumb. So medical devices have profoundly changed. And if you've got a medical device, and let's just go from the least extreme medical device to your most elaborate patient monitoring device. So some of you may or may not have a smartphone, and that smartphone may or may not have a sleep app or a blood pressure app or a personal health app on it. That phone may speak to your smart device. So you may have a smartwatch, and that smartwatch may take your blood pressure, it may take your heart rate, it may measure your sleep, and in measuring your sleep, it may measure moments of sleep apnea. Now, those devices, when they speak to your consolidated information and they then transmit that device to you, would follow a series of international guidelines and regulations. So those guidelines and regulations, just to give you a sense on where telehealth and telemedicine come from and where they're going, are a set of design guidelines called the Continua Design Guidelines. These guidelines have been in place for more than 10 years and continue to be revised both by industry and by practitioners in almost a handshake collaboration with each other to try and get the best needs for the best therapeutic and appropriate outcomes as possible. They rely on something called fast healthcare interoperability resources. And on the next slide, I'm going to show you how that all looks together. And they're supported by a group called the Personal Connected Health Alliance. Why this is important is because every time we use a medical device now, it has within it, to a large extent, if not completely, the Continua Design Guidelines and the fast healthcare interoperable resource strategies and design criteria. And these then link through what are called APIs, or application program interfaces, between the device, a smartphone, and in many cases, your practice, your electronic medical record, or a hospital or health information system. Now, as that's moved, there's been a progression also in terms of the acts and regulations around the world that allow this to happen. So some examples of that, and then we're going to move on to specifically South African examples. In the USA, there is something called the 21st Century Cures Act, which is an act that specifically works to bring pharmaceutical products and medical devices faster into the healthcare market. You can appreciate that there's been a large degree of tension between those pharmaceutical and medical device companies that want more access to the market, and the more conservative practitioners and interest groups that want more testing to be done on efficacy and safety prior to things coming into the market. And that is filtered in many ways through something called the Global Digital Healthcare Partnership. And there's acts that sit and surround and embrace that. And the first is the HIPAA Act, which was the act on the portability of a patient's information back from 1996 in the USA. In the European Union, it's the General Data Protection Regulations, which, while were recently amended in 2018, go back as far as 1994. And in Canada, it's called the PIPEDA Act, which was promulgated and went into play last year. All of these acts talk about the relationship between you as an individual who has rights to your health, genetic, and biometric data, and how that data needs to be looked after. They also talk about you as the healthcare practitioner and what your obligations are in managing that data when you are providing telehealth and telemedicine services. So there is a significant amount of attention placed on how, when we use these smart devices, they need to be used in a manner that's safe. So I said to you that I would talk to you about the fast healthcare interoperable resources, and that's what this slide shows here. So you'll see on the left-hand side in the green banner, you have two types of devices, those called X73 devices and those called smart devices. These are your personal health devices. They would also include your patient monitoring systems. What these systems and these devices do is, whether it's a thermometer, a glucometer, a scale, a Holter, a blood pressure monitor, pulse oximeter, these devices capture that information using a variety of different biometric algorithms. In order for that data to go into a personal health gateway, they'll either use Bluetooth or they'll use a different kind of API, the application program interface, to handshake and transfer that data between the device and their personal health gateway. That then moves through two other gateways before it joins into a healthcare information system. Now, this could be a hospital system, it could be a laboratory system, it could be a reference system, it could be a third-party payer and health insurer system, or it could be your system with your electronic medical records. And this journey that you can see in front of you forms the framework, or what's now called the wireframe, of a telehealth and telemedicine practice in the behind-the-scenes aspect. So as you start thinking forward and saying, do you provide telehealth and telemedicine? You would also need to think about this journey to say, do you know which devices you want to use? Do you know how those devices' information is going to be transferred to yourself? And then do you know how you're going to manage that information for the best efficacy and the best support, both of the patient and of yourself and of your practice and the related liability that could occur? So let's look at our context, being the South African guidelines and regulations. We have the National Health Act, and that National Health Act provides rights to patients and obligations for ourselves. We then also have the Health Professions Council of South Africa's ethical guidelines. And specifically, I put here the booklets that I think are relevant specifically, but not limited to the South African context. You can download the entire series of booklets from the Health Professions Council of South Africa. It's a short 334-page read, but booklets 1 and 2 talk about your obligations as a practitioner. Booklets 4 talks about informed consent, because when you're practicing telehealth and telemedicine, the requirements for consent do not change. In fact, if anything, they expand. You've then got to look at your disclosure of information, which is booklet 5. You've got to look at how you manage your record keeping, which is in booklet 10. And you've got to look at the guidelines on telemedicine and telehealth, which is booklet 10. So you can see there, booklet 9, booklet 10 relate to record keeping and telehealth, and booklets 4 and 5 relate to what you inform your patient about and in the manner that you manage their confidentiality and privacy. All of these come together in addition with the South African EHEALTH strategy, which was a published strategy. Further, we had guidelines on telemedicine that were amended initially, and we're going to talk about this later, on the 9th of March, as COVID became more of a reality for us as a pandemic. Those guidelines were expanded on the 17th of April. And what those guidelines did, and we'll talk about this in a little while, is they expanded the scope of telemedicine practice to allow for telehealth for the duration of the pandemic. Once the pandemic is over, the Health Professions Council will review the use of telehealth, and we will then get a new set of guidelines as to where to move forward. Further, and importantly, the act called the Protection of Personal Information Act of 2013 has come into full effect as of the 1st of July 2020. And that, in the South African context, in a similar way to HIPAA and GDPR and PIPEDA in respectively the USA and the European Union and the Canadian environment, protects and defines how we protect as practitioners a person's private information. So this should give you a landscape around understanding that telehealth is not simply connecting with your patient using technology. It's much more than that, and it's governed in a manner that we need to be fully aware and conversant of. So telemedicine in its own right is the practice of medicine using electronic communications, using information technology and any other electronic means between a healthcare practitioner in one location and a healthcare practitioner in another location for the purpose of facilitating, improving, and enhancing both clinical, educational, and scientific healthcare and research. And the purpose for this initially was to specifically provide care in underserviced areas where there weren't as many specialists or persons with specific medical disciplines. And the idea was to be able to broaden that. So this is described under section 3.1 in booklet 10 of the ethical guidelines. And the principle here was that one healthcare practitioner would be with the patient, and a separate healthcare practitioner in a remote area would be able to provide support, facilitation, and advice to that diagnostic and therapeutic experience. The principle at that point was that telemedicine involved secure video conferencing or other kinds of technology, telephony, that would enable healthcare practitioners to replicate the traditional face-to-face consultation. And it refers to any circumstance where information around a patient is exchanged electronically, on or offline, formally or informally, or when there is a need for a second opinion. So this was the traditional defined telemedicine prior to March of 2020. Now, in March 2020, there were some telehealth amendments. And what happened, and this is largely because of the inaccessibility created firstly by the lockdown and secondly by the progressing pandemic that we're currently in, is that telehealth, which was separate from telemedicine in the fact that a practitioner could have a consultation with a patient without another practitioner being present. Now, the statement there was that telehealth should preferably be practiced where there's an already existing practitioner-patient relationship. And where there wasn't a relationship already existing, we as practitioners need to consult where the consultation is done in the best clinical interest of the patient. There were two communications, both on the 26th of March and on the 17th of April, supporting that. They also went on to say, in the disciplines of telepsychiatry and telepsychology, telehealth is permissible even without an established practitioner-patient relationship. That's a pre-existing definition. And one may, as a practitioner, charge fees for consultations undertaken through telehealth platforms. And some of you will recall that there was a large debate happening around March and April as to whether one could charge a full fee from a funder and from a patient for a telehealth or telemedicine consultation. The issue that came out from that was you are fully entitled to charge a fee, but one must be aware that the fee must be commensurate to the service, and that if you're over-servicing or if you are under-servicing or if you're charging inappropriate amounts, that would be frowned upon, just like it would be frowned upon in any other form of your ethical practice. So the guidance provided by the Health Professions Council is only applicable during the state of this pandemic. Now, this pandemic, in terms of the Disaster Management Act, the state of emergency was first extended to the 15th of June of 2020. It was then extended through the regulations to the 15th of July, and it's now been extended further to the 15th of August, subject to review. But during lockdown and during this time of the pandemic, the amendments to telehealth persist. This may change, and it may be expanded or it may be reduced. But at this point, we need to be able to ensure that we can provide services remotely to persons, preferably from their normal place of residence, because we don't want to take immunocompromised persons. We don't want to take persons with comorbidities. We don't want to take vulnerable persons, whether elderly or young or immunocompromised, and place them in a position where commuting to their consultation or being in the consultation room puts themselves or yourself or your staff or other persons at risk. So That's the context of how telehealth has matured and developed through the context of the South African pandemic experience. Let's pause for a moment and say, how has COVID-19 changed the outlook for telehealth? From a consumer or from a patient point of view, and this is a study that was done and published in April this year, only 11% of patients were using telehealth in some form in 2019. Because of that desire to avoid exposure to COVID-19, with more than 70% of in-person consultations cancelled. And I'm not sure about what your practice looks like. I know my practice reduced profoundly, but there are more than 76% of patients now interested and willing to use telehealth moving forward. And 74% of people who use telehealth report high satisfaction. I'm going to show you some trends that have come out from the American Medical Association on this. But the question that one might ask oneself in one's own practice now is, are you able to do telehealth safely in your practice? I spoke to a practitioner after a presentation recently, and that practitioner said, it's all good and well talking about this, but I have a practice where I need the patient present. And the recognition there is telehealth is not always going to work for all disciplines in all circumstances. So you need to understand in your own practice, can you safely provide remote diagnosis? Can you safely provide remote care? And can you safely engage in a manner that's both appropriate for yourself and for your patients and for your patient's extended family? And so when we look at that, the number of telehealth consultations for providers has increased between 50 and 170 times since the onset of COVID in terms of being able to provide patient care. More than half of providers, more than half of us as practitioners view telehealth more favorably than we did before COVID. And more than 64% of people are more comfortable using it than before. So we've seen not only has there been this progressive shift towards digital health and towards remote healthcare and telehealth over the last 6 years, but because of COVID, because of the last 6 months, there has been a step change in how we view consultation. I'll take you back to the first slide and say, how do you define a consultation? And do you consider that a remote consultation or a virtual consultation will give you the same efficacy and patient effectiveness and quality of care that a face-to-face consultation would hold? So this is a study called the Digital Health Study that was done initially by the American Medical Association in 2016. It was then repeated in 2019, and interestingly, it was published in the first week of February 2020. So this excludes the impact of the last 5 months of COVID. So you can appreciate that subsequent to this, there would have been a profound uptick in these 4 key areas. So the first key area that was found in the survey is that there's been an increase in the number of physicians who see a definite advantage in the use of digital tools. So primary care practitioners have seen this as a much faster growth. It's an interesting thing to see that those over the age of 50 haven't really seen an advantage, but equally, they're not seeing a barrier to the use of telehealth. There's been an adoption of digital tools, and that's grown significantly amongst all clinicians and physicians, regardless of gender, specialty, or age. So we're going to look at some of those tools, but the increased efficiency and patient safety were key drivers for the use of these tools. And one of the things that was interesting, and as we consider this in terms of our general and our practice liability, is the tools needed to be covered by standard malpractice insurance. And you can see there, they mention that data privacy concerns have increased. Now, in our world, because of POPI, the Protection of Personal Information Act, and because of the requirements to manage patient data safely in terms of our ethical guidelines, we have very strict data privacy concerns that we need to stay aware of. And in your case, it would also include how you manage your social media and how you manage the sharing of data over digital platforms. And you can read that in booklet 16 of the Health Professions Guideline, the ethical guidelines. Thirdly, there's been an adoption of remote care tools, such as televisits and remote monitoring. And that has seen the most movement of all types of telehealth during this digital health survey. Now, what's the benefit of that? Is amongst other things, it provides remote care to patients in a manner that is significant as a driver for using these digital tools. And part of that is being able to monitor both compliance and progression of a chronic illness. And that adoption, as I showed you on the previous slide, not only did they perceive that it would increase significantly, as a result of COVID, it has increased significantly. And finally, the fourth finding that they found was there's an emergence of technology, and our awareness of this emergence in things like artificial or augmented intelligence is fairly high, which means that we know a lot more than we used to know as practitioners around digital health and the effect that digital health has on our world and on the work that we're doing. So let's just pause for a moment and have a look at that. In terms of virtual visits or televisits, what we're defining within the South African context as telehealth, we have seen that there's an increase in the communication and sharing of electronic clinical data. And that's between ourselves and our patients, and between ourselves and to other practitioners who we make referrals to ensure that there's a smoothness of transitions of care. So you'll see under current state there's a technology adoption life cycle. That life cycle is a curve that was first presented in this form by a author called Everett Rogers in a book called The Diffusion of Innovation. That was in 1984. You'll see there that the early majority, meaning the large proportion of the more conservative practitioners, are now beginning to use televisits. Why do they use them, and why are they saying that they're good? And this is part of that AMA digital trend survey that I showed you in the previous slide. The first is this kind of virtual visit increases patient convenience. It's perceived from practitioners to increase work efficiency, and it allows the practitioners to provide care remotely in a manner that they also feel improves their patient-doctor relationship and increases patient safety. Now, in other presentations, and when we start talking about medical risk from a medical errors and professional liability perspective, we know that up to 24 out of 100 consultations have a patient safety risk element that could lead to an adverse outcome. So anytime we improve patient safety and improve the doctor-patient communication relationship, we reduce the risk of there being a medical error. We reduce the risk of there being a medical misadventure, which is an adverse outcome, even through best care, and we reduce the risk of medical negligence. Now, we can never fully remove those risks, but the more sentient we are, the more conscious and aware we are of what we're doing, the more we're able to provide safer, healthier care. And that's one of the principles around virtual visits and digital health, is to be able to provide access to care in a manner that's safe. So one of the key areas and one of the key factors that's changed is the use of apps and devices, specifically by chronic disease patients like hypertensives and diabetics, asthmatics, for daily measurement of vital signs. And that includes weight, blood pressure, and blood glucose. These readings come up for the patient on their smart devices, and they can be transmitted, and I showed you the slide earlier as to what the back-end mechanism of that looks like, to your offices. These can also be transmitted with alerts, whether the patient is either sending or not sending their information through, and or whether the information is inside or outside of preset alert ranges. So I know, as an example, that many diabetic or pre-diabetic patients measured their blood glucose levels. Those blood glucose levels are recorded on their smartphone, either for their own self-monitoring and or for their monitoring with yourselves as practitioners. So again, when we look at this, the key drivers here, the reasons that this has worked well, is firstly because it increases patient safety. Secondly, and adjacent to the increasing of patient safety, is it increases and improves patient adherence. Because when the patient knows that their records are being monitored and their results are being monitored, they are more likely to be more adherent with the treatment regime, whether it's the use of their medications or whether it's the measurement of their biometrics and health data, which is important. Equally, what it does is it improves your diagnostic ability because you're getting regular data into your rooms around key measures. And those measures could relate to the kind of work that you do. If it's blood pressure, we used to have patients wear a halter and go away for 24 hours and record that information and then bring it back. We can now get hourly, if necessary, blood pressure data coming into a specific form on a specific format. What it's doing is it's improving work efficiency. Because it's improving work efficiency, because it's improving patient safety and patient adherence, it directly improves your patient-doctor relationship. And one of the things that we know on the medical error side of things is that one of the typical causes of medical errors that leads to the risk of litigation is the level of communication between you as the healthcare provider and the patient who is receiving that information. So by being able to provide remote care, like remote monitoring, and improving communication and improving both diagnostic ability and patient adherence, you are promoting good outcomes versus poor outcomes and limiting the risk that those bring to adverse outcomes. So this is a case study of Portugal, who's been now doing this for a significant amount of years. In fact, 27 years is how long telehealth has been an active part of the Portugal health system. They have a national strategic telehealth plan where telemonitoring is actively encouraged. They have self-service portals like electronic health records, where the patient can come onto their health record, have access to their health record. There's portability of that health record through a data wallet. The patient can make appointments. They can ask the practitioner questions. They can get their prescriptions reboarded and sent to them. They do a lot of work on teletriage and telehealthcare. Equally, they do telerehabilitation. And it's compelling for me to see how in areas where patients are remote, that if they have a screen and they have bandwidth, and now we're assuming, of course, that there is a screen and bandwidth and not challenges relating to both the amount of data that is usable and sometimes potentially whether there is load shedding or not. You have to bear that in mind if you're running a telecare and telehealthcare practice. But where there are those perfect components, the patient is able to do telerehabilitation with the therapist remotely. Interestingly, to support this in Portugal, practitioners get paid an extra 10% for a teleconsultation because it's
Brad? Sorry.
Yeah.
Sorry to disturb your thoughts. Sorry, man. Your signal was breaking and you were pixelating terribly. Is there any chance you can start in the beginning from this slide, this promoting health in Portuguese case study again? Would you mind jumping over to your other router quickly?
Not at all. Just give me a minute or two and I'll do that. Thank you very much. Stopping. No problem.
Thank you.
There's this there's technology that we called Live View. It's expensive. It's 10,000 Rand a day, but essentially what it does, what the TV networks do. So they run 6 SIM cards on the device. It's as big as a box. So we send one down to him. For instance, he hits a button. Then runs on 6 SIM cards and he has Wi-Fi. So we never have this. It literally goes and searches where there's capacity and balances them. So that's what what is this channel? Business Day and CNBC Africa. Yeah. And I saw this thing, it was like,
Hey, Brad. Yeah, that looks a lot better, huh?
You'd probably walk around with one in your pocket. You know what I mean? You're going to do something, it's like, cool, here I am.
Will you give us your presentation again there
Look how
quickly?
nice that is now.
I'm busy getting to that as we speak.
Cool, thank you.
Data.
Yeah, you know, it's,
Okay, so
Depends on what happens
it's,
downstream.
it's only that slide, hey?
yeah, from that port from
The rest
Portugal.
has been okay up until now.
Yeah, just
Draft.
before near the end of your last thought, it started getting a bit weird, and that's when I noticed it. But it really was falling now as you started the Portugal thing. So if we just start that, I'll edit it and put them together, and then nobody will even know the difference. So we'll start off. I'll start off your thought with that Portuguese slide full screen, and you can start talking, and then I'll bring you on screen.
Okay, and the rest of this has been fine so far.
Yeah,
Okay.
it's the world we're living in, man. Data.
Data. In fact,
Data.
part of what I was saying in this presentation was you needed to have enough data. So
yeah.
the irony is not lost.
You know, it's great technology, except you can also be isolated in a flash.
Okay, so I'll tell you when. Let me do this. I'm going to make this full screen. There we go. Okay, so stand by, and you can go for it whenever you're ready.
So let's take a moment now and have a look at a case study. And this is a case study done in Portugal with how telehealth has worked for them since the mid-1990s. This is 27 years now that Portugal has been promoting telehealth in terms of what is, in amongst other things, part of their national strategic telehealth plan. In order to do this, and where this comes from, is they believe that telemonitoring and self-service is a fundamental backbone to allowing patients access to practitioners while decongesting their needs to travel. So the principle behind this, and I want to use this also as a moment of self-reflection, is to say, if you have an electronic health record and you're using an electronic practice management system, patients can go on like they do in Portugal. They can make appointments, they can change appointments, they can send notes and requests and specific engagements with their practitioners. The practitioner can provide them with e-prescriptions, which can be filled remotely, so they don't need to necessarily go to the pharmacist. What struck me about this is you can also, in addition to teletriage, and I shared with you some of the teletriage technologies on the early part of this presentation, and providing telecare, you can also, through telehealth, share health information between different practitioners, and this is done very effectively in Portugal with data wallets that they have, where their medical records are kept and transferable. But also what they do is they provide tele-rehabilitation. Now, one of the challenges that we find with patients is if they have had an injury, they're not always as mobile as they could be, and so public transport or private transport or access to rooms is sometimes restricted. So having adequate bandwidth and having technology on both sides, in other words, a screen where patients can see on both sides. The patient can see on one side, you as the therapist can see on the other side and instruct, allows for there to be a significantly large amount of rehabilitative and self-care that's happening. And that's made a very effective triangle of triage, care, and rehabilitation, all within the telemonitoring structure that we spoke about earlier. In order to promote this and to make this happen in the Portuguese healthcare system, there's an incentive for practitioners in Portugal. They get paid 10% on average more for a telehealth consultation than they do on a face-to-face consultation. So this is an example of how a country has taken telehealth seriously, embraced it, progressed with it, created the opportunity for medical devices, digital trends and technologies, and common practice to flourish and blossom into a very robust telehealth system. So let's look at some of the current challenges now that are happening in every country. And I'm using the European Union as the principal example here, because this is the most reliable information that we've got on both mHealth, which is mobile health, and eHealth, which is electronic health challenges. So some of those challenges, and you'll see it on the slide in different areas, is the funding, because sometimes these are expensive initiatives. you would need to upgrade your rooms, or you would need to upgrade your technologies, or you would need to upgrade your storage. You would possibly need to purchase new tools like digital imaging devices or digital communication platforms. So funding is a barrier in many areas. Having skilled employees who can do this work, because it's not only yourself that needs to support this, but you may need a practice administrator, you may need a medical assistant to do this, costs money. In addition to that, it takes training. And so being able to find skilled staff who can use these devices or can integrate this into our daily practices is more of a challenge. That also speaks to a challenge for us in terms of the second piece, which is interoperable standards. Are we able to take what you saw on an earlier slide, where different devices use different platforms and different communication tools, and combine that information into a single medical record or a single communication record between yourself and patients on one side, between yourself and other practitioners on the second side, and between yourself and medical insurers and funders on the third side? Because one needs to realize, as one does telehealth, that you still need to keep good records. Now, as soon as you provide a telehealth consultation, you need to bear in mind that part of the interoperable standard is you need to be able to record the telehealth consultation. And if you're not recording the consultation end to end, you need to be able to make good detailed notes, either handwritten or typed notes of the consultation. And part of that is you need to get the right consent and you need to do the right record keeping. And that requires sufficiently skilled employees, including yourself. So you can see that there are challenges to bring this into eHealth into place. With that, and as we go forward, I'm going to share with you 2 slides on what are regarded as the 3 priorities in these other countries in terms of eHealth. And eHealth here, we're looking at digitally connecting care. It's a universal effort, because if I'm making my notes and I am treating my patient using electronic medical records, and you're doing them using handwritten notes, how do we share information with each other? If I run a digital health practice and you run a low-tech practice, how do we communicate to the best effect? So you'll see in the 3 priorities that are top in Germany and in the UK, the implementation of electronic medical records is a key issue. And it persists because as we go forward with this, one has to think about how that relates to, and you'll see this in the next comment, which is the pink bars. Germany, the Nordics, and Spain are asking the questions on how do we ensure IT security? So if you're now using electronic medical records, like the records in your practice, or you're using a technology, a video streaming technology, that video streaming technology, to use a few examples, could be Zoom, it could be Skype, it could be BlueJeans, it could be Starleaf, it could be WhatsApp. Any one of those that you use needs to have levels of encryption to ensure that it can't be cyber hacked by a third party. It also needs IT security to make sure that the information that you gather on that patient doesn't make its way into a digital forum that could be shared without the patient's consent. Because bear in mind, as you go through this and we start looking at IT security and electronic medical records, you also have to make sure that your patient is giving you written informed consent for the digital storage of the records that may or may not be shared with other parties. Then, because of that, you also have to look at improved access for clinicians and, importantly, system usability. Does your practice allow you to provide electronic records? Does it allow you to provide safe electronic and telehealth support? Do you have a stable enough system that keeps the bandwidth good? And what does your storage system look like? Once you get that information coming in, how are you saving it? And are you using the adequate password protection? Do you have different passwords for your different programs? A lot of practitioners and a lot of people have the same password for their phone and their laptop and their electronic record system and their storage. So you'll need to know whether, both in terms of system usability and IT security and the use of your digital system, whether you have the right 1 or 2 step encryption to allow access to be limited or controlled. Finally, let's look at what's coming up in electronic healthcare in years to come. And these are some of the predictions of what's coming up as put out by the HIMSS Insights, which was only 7 months ago, but 7 months ago feels like a really long time ago in patient records. And the first and the top trend is personal health records. How we record our patients' records, what access they have to those records. You'll recall me earlier talking about HIPAA, the health information requirements in the USA, and FHIR, which are the same in Canada. So North America has very strict rules. So does the EU, and now through POPI, so do we. So how we manage patient information, how we transcribe that information off written records onto electronic records is going to be a challenge. And I know some practitioners who I've worked with who've said, no problem, you can prize my pen from my cold, dead fingers because I'm not moving from written records to electronic records. And that's fine, but those are still personal health records. One of the things that we need to bear in mind, especially as we move towards limiting our own practice liability and preserving patient information, is that the patient has the rights to access to their records. Third parties may, through the permission of that patient, have access to their health records. And health records need to be complete and they need to be legible. So I refer you back to the ethical guidelines on the keeping of health records. So the HPCSA guidelines, booklet 9 specifically, points to the importance of health records, and those are underscored by the National Health Act. But how we keep personal health records, I think, will become increasingly digitized as time goes on. There is also the servicing or the provision of telemedicine and telehealth by providers, by us, by practitioners, both in a hospital and in a primary care space. We're already seeing this happening with pharmacists and with the dispensing and collection of medicines in South African peri-urban and rural areas. And a very accessible example, if those of you ever go to a filling station, at the Total stations as an example, you go into the convenience store and there's a vending machine where you can buy over-the-counter medicines and other primary healthcare products. Equally, there are some digital pharmacies that are providing access to patients for their medicines, where they go to a smart device close to where they live. They use a biometric entry system to open up their cubbyhole, and they get their medicines off the back of that usage. What that does is that cubbyhole communicates back to the pharmacy and communicates back to the prescribing practitioner to tell them that the medicines have been collected. And in telling them that the medicine has been collected, they have an idea what patient adherence and patient compliance is looking like. And so that, combined with the requirements that we're going to see increasingly on the use of more artificial intelligence and machine learning in early diagnosis and record keeping, are some of the trends that we're going to see coming. So as we pause here and we think about this, the challenge will still be how we create cross-organizational electronic patient records. Now, cross-organizational may mean between practitioners, primary practitioners, secondary practitioners, and tertiary practitioners. In other words, in your rooms, in the hospital setting, and in a post-discharge rehabilitative setting, but it will also include the pharmacy environment. It will also include the health funder environment, and in certain instances may include a public and private clinical exchange where information is kept. So as we reflect, and in summary, I want to share with you 4 ideas. The first is, what is your view on a consultation? And does telehealth form part of your future view of what an integrated model of care could be? If the answer is yes, it does. The second question is, do you have a checklist to make sure that your telehealth consultation is complete? Now, Atul Gawande speaks about checklists in his book called The Checklist Manifesto. He's one of a number of great authors on this. In his book, he talks about quality improvement happening when we repeatedly follow the same steps in the same order to get the same outcome. So your question, if you were doing a telehealth consultation, would be, have I got the infrastructure right to provide a safe remote or virtual consultation? Number one. Do I have consent from my patient in a written form to provide these, and am I storing that appropriately? Number three is, am I managing the digital platforms in the best possible way? And number four is, have I recorded the patient experience, both my diagnostic reasoning, my consultation, my treatment protocol, and my plan and my patient's response in a manner that is recorded safely and retrievable. At this point, I want to thank everyone for attending. MJ, I'm handing back to yourself.
Thank you, Brad. E-health is certainly a very, very interesting and exciting space. And I think that practitioners would, I'm going to start that again. Thank you, Brad. E-health is certainly an exciting space, and practitioners will need to focus their attentions. Fuck's sakes, what am I trying to say? I had it in my mind as Brad was speaking. E-health is an important space, and practitioners. Okay. Thank you, Brad. E-health is certainly an exciting and. Fuck me. Thank you, Brad. E-health is certainly an exciting space and somewhere that practitioners will need to focus. With the advancements of technology, we all feel that it's an area that certainly cannot be ignored. For any practitioners who are listening today and would like to find out more about the CPD initiatives that Genoa offer, please will you follow us on either LinkedIn or alternatively on our YouTube page, the details of which are on the page currently. We look forward to seeing you at our future events. Thank you. Do another one, eh? Okay. Throw it out. All right. Thank you, Brad. E-health is certainly an area that practitioners need to focus on with the advancements in technology. It's a space that can add true value to the practitioners' practices as well. For those of you who are listening in, we hope that you enjoyed this CPD series. And should you want to hear more about the offerings that Genoa underwriting managers are bringing about, please will you follow us on either LinkedIn or alternatively our YouTube page, the details of which are on the screen now. Thank you. One more. Fuck, man.
You know what, MJ, if we do this every day for the next few weeks, you'll be slick at it by August.
Thanks, Brad. Thank you, Brad. E-health is certainly an exciting and dynamic area of medicine at the moment, and our practitioners should take note of the exciting developments. Thank you very much for sharing your insights on this topic. Fuck me. Let me start again.
Brad, sorry, would you just leave that last slide up for us, please?
Oh crap! Sorry, man.
Doesn't matter, like
yeah.
podcast or
else. I was busy sending to Nicola the presentation. I'm sorry.
It's okay.
Yeah, it's my low voltage Friday.
It's good that it is nearly the weekend, though.
I'm so relieved it's the weekend. I think I'm my bandwidth is low. Okay. Sorry, guys. I feel like a fool. Okay. There you go.
Thank you.
Thanks very much. Thank you, Brad. E-health is certainly an exciting space that all of us need to pay close attention to. And thank you very much for sharing your insights on the topic. For those practitioners who've enjoyed this CPD event and who would like to find out about future CPD events, please will you take attention to the on-screen links that are available. First of all, you can follow us on LinkedIn, alternatively on our YouTube page. Thank you, and we hope you enjoyed yourself.
Okay. It's all good. Let's do one more.
Okay. E-health. Thank you, Brad. The developments in eHealth are certainly something that are... Oh, fuck me. Why am I battling here? I'm like a...
Hey,
I'm
MJ.
Like let me take you off here. eHealth is certainly of interest to all listening in, and thank you for sharing your insights in the space. No, go again. What am I trying to say? Thank you, Brad, for the insights into the eHealth. The developments are huge. Thank you for sharing your insights. Follow us here. Okay. Thank you, Brad, for sharing your insights into the eHealth world. It certainly is an interesting space. For those of you practitioners who have enjoyed this CPD event, please will you pay attention to the links that are appearing on your screen now, and either follow us on LinkedIn or alternatively on our YouTube page. Thank you, and we look forward to welcoming you to future Genoa Underwriting Managers CPD events. We look forward to welcoming you. Okay. So for those of you who have enjoyed this CPD, thank you, and we look forward to welcoming you to future CPD events. Okay. Thank you, and we look forward to welcoming you to future CPD events. Fine? Shall I just do the last one from the top? One more. Sorry. eHealth. Thank you, Brad. Genoa. Thank you, Brad. eHealth is certainly an exciting and dynamic space, and something that all of us need to pay attention to. Thank you very much for sharing your insights into... Oh, fuck me. Guys, I can't do this, eh? Fucking battling like a simpleton here. Thank you, Brad, for sharing your insights into the eHealth space. It certainly is an interesting and dynamic area. For those of you practitioners listening in who feel that you would like to hear more about the CPD initiatives that Genoa Underwriting Managers offer, please pay attention to the links that are appearing on your screen now. Either follow us on LinkedIn or alternatively visit our YouTube page. Thank you, and we hope that you enjoyed the event. I don't know, there are a whole lot there. You guys might have to just cut a few and see what you can.
Just see what we can make put together. You know, I think you've nailed it. Do one last one from the top right through, and then we happy days.
Thank you, Brad, for sharing your insights into the eHealth. Right. Thank you, Brad, for sharing your insights into eHealth. It certainly is an interesting and dynamic area of... Oh, fuck me. No. Let me just... yeah, I'm just panicking now. I'll be good. I'm just... Okay, I'm good now. You'd think that I could get this, eh? Thank you, Brad, for sharing your incredible insights into this dynamic space. For those of you who have enjoyed this CPD presentation with Genoa Underwriting Managers, please take the time to follow us on either LinkedIn or alternatively on our YouTube page so that we can keep you informed of additional CPD initiatives that will be following in the coming months. Thank you, and we're glad that you enjoyed the presentation.
Just the last one, just a thank you.
Thank you, and we hope that you enjoyed the presentation. Okay, sorry about that.
Done. Thank you very much.
Only 10 takes, Brad, for me there.
Oh, well, some days are like that, hey? We know what we want to say. We just can't get it out there.
Yeah.
Okay, perfect, guys. Thank you.
Brad, thank you very much for all of your time and taken to do these. I think they've been